And welcome everybody to this week's Maternity and Midwifery Hour. My name's Sue Macdonald and I'm the curator for the Maternity and Midwifery Hour and the Maternity and Midwifery Festivals. And it's my pleasure and delight to be chairing this evening's sessions, which is going to be fabulous. I know and we've got even a snippet, I think, of something even specialer right at the end, I think, from one of our guests. And we're joined this evening by Professor Calvin Moorley, who many of you will know, and Maria Rowntree, that also many of you will know. And if you don't know now, you will do know very soon. Now, as we always do with our guests, we always put them on the spot to ask them to share just a little moment of the week, something nice and something frivolous maybe, or something just positive. So can I put Calvin on the spot, please?
My good moment has been, believe it or not, I've just returned from holidays. So the good moment is holidays. I was in Ghana for roughly 9 days and we enjoyed ourselves thoroughly in 33 degrees temperature. It was wonderful.
Oh, you're making us jealous. 33 degrees. My goodness, we could do with some of that. And I bet it wasn't the humid heat we get here.
No, not at all. Because we were on the coast as well. So we did get the sea and the sun and the sand and all of that. It was wonderful.
Fabulous. Thank you for sharing that. Now, we're all green with envy now, of course, with that. Now, how about Maria? Have you got a moment?
It's the opposite. Mine's totally the opposite. So I was driving around today after there'd been heavy rain, and I just was in wonder how so much rain can completely change the landscape to the point where I drove past a field that had been flooded and it looked like a reservoir, and I hadn't driven in that area before, but it's so beautiful. I thought, oh my goodness, this is beautiful. How did I not know this was here? And I came home and looked at the map and realised it was supposed to be, it's a floodplain, but it's normally a field. So I just love how the weather, even in its darkest moments, can change our landscape and makes you realise that you're alive and that every day is different. So that just felt quite touched me a bit, really.
No, isn't that lovely and positive? How fantastic. So we've had sunshine, we've had rain, but lovely and positive from both our wonderful guests. And that's just a fraction of what we're going to get this evening. So thank you very much for sharing that with us. I'm going to look at the rain differently and not be so negative. Thank you, Maria. And the sunshine, well, I'll just carry on being jealous of Calvin anyway, being away in that sunshine. Now, I'm just going to just remind people, now there'll be some new people with us this evening. And if you're new to the Maternity and Midwifery Hour, huge welcome. And I hope this will be first of many. Now, we started right at the beginning of the COVID pandemic, when the lockdown was made in March 2020. I can hardly believe it seems in one way so close and in other ways so far away. But we really started the maternity hour because we knew we couldn't do conferences, we couldn't do study days, we couldn't do the face-to-face stuff that midwives and student midwives and all the people working in maternity services alike. We had to have some way of connecting people and providing information. And at that time, when we started, we put a lot of information about changes due to COVID and what COVID was and what was happening. And of course, over the time, it's changed. The content's changed, but we've carried on. We're coming into our 4th year. I can't believe it. I think I said last week it was our 3rd. That shows how confusing it can be. Anyway, the beautiful thing about the Maternity and Midwifery Hour, and if you're first here for the first time, you'll know this now, is recorded and you can access it free anytime afterwards. You'll get a recording afterwards if you choose to have that. And like all our festivals, everything's recorded. You don't miss a moment. You get your little box set and you can go all the way through. And as a midwife, I love that because I don't like to miss anything. So my little secret is, get everything you can from this. And it is fantastic if you're doing any projects, your dissertations, if you're doing assignments for university or college. It's a wonderful resource, all on Netflix, all kept. And I think from Neil Stewart was saying the other day, I think we're about 1,700 episodes or whatever. We've got lots and lots of material. So you just have to go to Netflix and look and put in the search engine to find what you want. Now, if you want something a little bit more focused, you can have a subscription and then you can get all the box sets. And that is all sort of curated in a slightly different way with lots of reflective activities and things, which is done by our lovely Dr. Jenny Hall. So that's fantastic if you want to access that. Now, I'm also going to say, and it's on the top of my mind because of all the COVID, the things that are in the press at the moment, big thank you to everyone who's working so hard at the moment to provide care. I know it's winter, there's still COVID around, people still getting poorly, and we are short of midwives. Whatever anyone says, we're short of midwives and we need every midwife we've got. So thank you to all of you for all that you're doing. Just take care of yourselves. Don't, look after people the way you are looking after people yourself. Look after yourselves. And also, I'm just doing a quick news flash. I'm quickly looking at the time because I don't want to miss a moment of Calvin and Maria. Just to remind people, if you didn't know, there's a series on TV, and I've seen it, and I would say that if you've been affected, obviously heavily by COVID, you now may not be the time to watch it. But if you don't know much about it, this program is fantastic, and it's on tonight. The third one's on tonight. Other news, congratulations to Clea Harmer of Sands. She's been appointed as the chair of the NHS England Maternity and Neonatal Stakeholder Council. So congrats to Clea, fantastic choice of person to lead that group. We've got also a historic day in Australia, first ever state level chief midwife officer. Midwife Liz Wilkes has been appointed by Queensland Health, and she's got the remit, to drive some maternity reforms, and that's really good. It's always good to know that people have got a chief midwife really pushing service and looking at maternity services and neonatal care from that high level, as high as possible. So that's fantastic. Other things that you might know, and I say this also, have a look at your resources sheet because a lot of links there that are quite useful that I talk about. For example, there's a big National Institute of Health and Care Research, NIHR, and this is a UK thing, and they look after a lot and fund a lot of research within health. And they're having a celebratory event for International Nurses and International Midwives Day on the 8th of May in Birmingham, and they're focusing on successes in failure within and the future within nursing and midwifery research. So that's set to be really good. So there's a link there to register if you'd like to do that. There's also an investigation going on at Parliament into NHS leadership performance and patient safety, and that's been in the press a huge amount. And if you want to make any comments into that, you can either go through the Royal College of Midwives, because they're seeking information to put their submission in, or you can go direct to the site, and that's both of those are in your resources. Now, also, I would say this fortnight is Fair Trade Fortnight. I think it ought to be fair trade all the time, actually, but that's the fortnight, these awareness days. And interestingly, very interestingly, today is International Mother Language Day, which is designated by UNESCO and UN, supporting multilingual education and learning, which I think is very, very apt for our topic this evening. Because we're going to be looking at really the value of learning through initiatives like the Dame Elizabeth Anionwu Inclusivity Fellowship. And Dame Elizabeth has spoken on the Maternity Hour a couple of times. Fantastic. We love Dame Elizabeth. This is all about the discussion of complexity of understanding privilege, inclusion, and the impact of power, and what we should be doing to support women and their families for whom English is not their first language. And it's a very complex issue. And I'm delighted we've got two fantastic people speaking this evening. And the first is Dr. Calvin Moorley, Professor of Diversity and Social Justice in the Adult Nursing Department at the London South Bank University. He's got a background in public health and diversity in care. His research focuses on the interplay of gender, culture, ethnicity, and health. And since graduating from University of Essex as an adult registered nurse, he followed a very clinical academic career, being very close to clinical nursing, particularly in the critical care environment. And on this is just, I ought to remind everybody, these are just edited highlights. His whole CV is online, so please do look at that when you're looking later maybe. But one of his many achievements was the fantastic launch of the Dame Elizabeth Anionwu Lecture for Inclusivity in Nursing and Midwifery, and the Anionwu Awards for Inclusivity in Nursing and Midwifery. So that's with Calvin. And alongside Calvin is Maria Rowntree. She was an experienced midwife, poet, and a Dame Elizabeth Anionwu Fellow for Inclusivity in Nursing and Midwifery. And Maria chose to improve the use of professional interpreters as her fellowship project. And you'll hear a little bit more about how that actually works in a moment. And this has enabled her to further explore issues surrounding diversity whilst developing her leadership skills. Maria has also been appointed as a Royal College of Midwives representative in addition. So welcome to Maria and to Calvin. The screen is now yours, and thank you very much for being with us this evening.
Thank you very much, Sue. And thank you everyone for joining us from all around the world. So in case you're trying to think and place my accent, I'm originally from the Caribbean. I was born and brought up in a lovely twin island of Trinidad and Tobago. And in about 2021, we were rated the happiest nation in the Caribbean. So it's a lovely place to be. And last weekend, we would have had Carnival in Trinidad, which is better than the Brazilian Carnival. Just my little tip. But welcome to our Brazilian followers as well, if they're listening. It's a pleasure to be here and alongside Maria tonight to just talk to you and share with you all first a little bit about me and the fellowship, and then we're going to really move on to the meatier bit, which is Maria and her work. So just for context, most people know about Mary Seacole, who was a nurse who served during the Crimea War. But we know because of biases and racism in play, Mary Seacole's work had been played down as opposed to Florence Nightingale. Mary Seacole now has her work, and what she did is gaining recognition momentum. In my early stages after I completed my doctorate, so it's my postdoc really in 2012, I was awarded a fellowship by the Royal College of Nursing to be a Mary Seacole, a leadership program, named the Mary Seacole Leadership Program. And I learned so much from that program. I had women like Janet File, who some of you are UK midwives would know, Obi Amadi, Professor Carol Baxter, Dame Elizabeth herself. And they were all women, and Tom Sanford at the time, all women who guided me and molded me into this whole area of inclusivity and everything I did and wanted to do. But then that program moved away from the 4 unions and colleges running it, and it sort of went to a different organization. But what that program did, it instilled in me what a fellowship can do, how a fellowship can help nurses bridge what they experience. And I didn't know much about Mary Seacole, but what I started to realize was that her values aligned to my values. And we had those commonalities. So as I grew and I developed, and my work began as a professor, looking at the interplay between culture, gender, race, and society, I started to think, how are we equipping nurses and midwives and health visitors to actually go and deal with the problems of exclusion in our society and communities? And Dame Elizabeth and I were chatting one day, and we were talking to her then, and I went away. And then Elizabeth will tell you this. I rang her up one day and I said, Elizabeth, I'm not going to wait till you die to do something in your name. I'm going to do it while you're alive. And she just went, oh, charming, Calvin. Thank you. You know, and there we had that conversation because I was seeking Elizabeth's approval before I used her name. And then there were wonderful people at Health Education England who I contacted, and they listened to me, and they heard what I wanted to do, and we did a proposal for a pilot project, and we got the funding to run the Dame Elizabeth Anionwu Fellowship for Inclusivity in Nursing and Midwifery. Brilliant. It started, we recruited a cohort, and part of that program was for nurses at any level. So you could be an entry level, a midwife at entry level, a health visitor, but you needed to part of it was to expose people to the space, because we often talked about space in the program, where space is important for thinking, for reflecting, for understanding, and seeing where we go and how we navigate things. So we created this space, and we said, this is how the fellowship's going to work. It was really dynamic learning. It was more of a relationship building program. And it'll sound wedgy when I say it. We were working with nurses and midwives on this fellowship to develop a relationship with their patients and clients who we'd never seen, and they may never know who they'll meet until they meet them. So it was building this side of the relationship. How do we build positive, inclusive relationships? And that's what the fellowship was about. How to be inclusive in gender, race, disability, sexual orientation, all these areas. How do we begin to do it? And as part of that 9-month fellowship program, we had participants or candidate students, they needed to do a change project. And Maria will tell you later what her project was. So for me, it was really and truly about how we opened up a space to run this fellowship program. Alongside the fellowship program, I also launched an annual lecture. Our first annual lecture, which is available on YouTube, was delivered by Professor Laura Sarant, and she looked at how much progress have we made since, as the first lecture. Our second lecture was delivered last year in October by Nicole McIntosh, who is the head of nursing for London for WTE, previously HEE. And Nicole looked at inclusivity and inclusive language and how language matters, something, again, you'll hear from Maria today. The program, you may want to ask me, how do I get onto it? I'll tell you really quickly. It's an application process. It's only for people in England at the moment. So I'm sorry about the 4 nations. We haven't gotten there, but we will try to. It is funded in terms of your time for the program is paid for. The educational material is funded. It's an agreement with your host hospital trust, so they pay your travel if you're outside of London. And we try not to be London-centric. Our first time we had candidates from all across, so which worked really well. We had a wonderful celebration at the end of the program where everyone comes together and talk about their project, and they invite their colleagues, they invite their patients if they wanted to, whoever, were in their circle that supported the work and they want to know about the work. So for me, the Elizabeth Anionwu lecture and fellowship really and truly is signaling a message to our nation. First of all, and when I say our nation, our patients, those who come into our care, that we want to get it right for them. We know we don't always get it right. And what this program does, it signals an investment in nurses and midwives and health visitors who want to make a difference, who we can then go out and see how it changes things. You'd hear of Maria's project today. One of the other women on the program, her project was looking at how people feel valued and included in their appraisal process. So, when you go for your appraisal and they give you a 3 out of a 5 or a 2 out of a 5, what does that really mean? Without any context, a number is quite punitive without context. So she looked at, and she's changed it for her department, and now her trust is adopting it as a policy of changing their appraisal process to be more inclusive, to take the views of staff. So what we're looking at is really how we begin to change systems through a project like this. So our fellowship program, as I say, signals first to the nation, who are our patients and future patients, that we want to get it right. We want to include them and make sure we do it, the way it should be done, care, that is, deliver care and health promotion packages. Secondly, it's based on the values of Dame Elizabeth herself. You can read much about her. You can go and Google her. As Sue said, she's been on this program before, so you can probably search for those videos and look at those interviews. And then finally, so it's based on her values. And finally, it's about leaving a legacy around inclusivity, because if people feel included, they will also feel they belong. And if we include and people belong, then we'll cover all those characteristics we hope to cover that makes us different. So that's one of the aims, or the biggest aim of this project, is how we develop our staff to get it right for our patients. And I'm going to leave it there for now, if that's okay. Thank you, Sue.
Fantastic. I think we're moving now to Maria.
I just would like to say thank you for that, Calvin, but
That's
you're very much
lovely.
underselling what the fellowship was. Just one of the most sort of inclusive and encouraging environments I've ever been in, and it changed my life. It's changed. There was so much stuff about how to use power, how to gain power, how to use that in a really inclusive way, and also to believe in ourselves. And I think Calvin's definitely not selling it in the way that it should be. I have never been in a learning environment that has been so safe and so supportive and so nurturing. And actually, every single person we met on that fellowship, be it the fellows or every single person that came to speak to us, they was just absolutely amazing. And we got to meet Janet Fowler. I mean, she changed my project. I'm going to talk about that in a moment. And we got to meet Ruth Oshikannu, and it was her that inspired the way I shared my story. And also Dame Elizabeth Anionwu herself, who wrote her book, Dreams from My Mother. And it was those two people really that made me share a story, because we would set a task for the fellowship event where we share our learning and also talk about our change project. Now, all of those things that I gained, I didn't expect to gain. I only wanted to go and get help to make this change, because it was just trying to get some help from some experts. And I never ever experienced or thought I'd experience all of these things for myself. And I wouldn't even be here talking to you today if it wasn't for that fellowship. So, Calvin, you're very much underselling it, but you are just absolutely amazing. So, and the course was phenomenal. And just having that opportunity to meet so many wonderful, passionate people. And I felt that we kind of met our people. To be in that space with people that have that level of passion is incredible. So to every single person that came and spoke to us, like Joan Myers, we had Roxanne, we had we had so many people that just fantastic. But yeah, it was an incredible privilege. So what I'm going to do now is I'm going to share with you the presentation, an audited one that I did on the fellowship event, and it's in two parts, but I'm just going to read straight through. And it will first just to demonstrate the importance of inclusion and our role in the NHS to do that. And the way I'm going to do that is I'm going to share my story. So I'm going to just share on here some slides. Can you see my slides?
Mhm.
There you go. Can you see that?
Yes, we can.
Yeah. So the story is a story of sharing light, very much inspired by Ruth and Dame Elizabeth, because that's how they talk about power and sort of privilege, and how we use that as a light and share it, and how important it is to share light, because by doing that, you make it brighter. So I'm going to just share with you my story of privilege and power. And so in honour of Dame Elizabeth. So firstly, we've already had some talking, and I want you to just consider what you may have considered about me so far. So obviously I'm white, I'm a woman, I'm middle class. You may have assumed I'm professional. You may have assumed I'm heterosexual and I'm cisgender. And you may have also assumed that I like cake, and I ate that piece of cake. And if you're watching this in HD, you may have also noticed that the menopause fairy has gifted me a beard. Thanks for that. For me to be my authentic self, I really want to share my story with you, because now you see a picture of a young girl who, at the age of 4, became homeless with her mum and her 1-year-old sister. A young girl who spent more time out of school than she spent in it, and who initially left school without a single GCSE. A child who experienced harm from many who should have protected her, and she became a teenage mother, lived in a relationship where she was made to feel less than worthless, and for a while believed the world would be better off without her. And these are just some of the reasons that that child felt excluded from the society in which they lived. And these are things that she had hidden for all of her life, for fear of being judged, not believed, and for fear that even more people will try and convince her that she is not good enough, and of those there have been too many. Now imagine this is a picture of a black girl who, on top of everything she had survived, she faced exclusion and racism, and that would be directly related to the darkness of her skin. So the darker her skin, the more likely she would be to be facing levels of racism. Or imagine she didn't identify with the gender that she was assigned at birth, and that she struggled not only with self-acceptance, but with constantly having to justify to society who she was. Or imagine that she were gay and her mother told her frequently that she was not normal. So I am certain that for me, just one more additional layer of exclusion or marginalisation, one more door being closed, one more barrier would have definitely pushed me over the edge. So now let me demonstrate to you the power of sharing light. Because now you see a picture of a woman who married the love of her life. He shared his light with her when she was unable to find her own and walked beside her as an equal and was the first person to really do so. She has been blessed with 5 children and 2 grandchildren. She attended university at the age of 35, finished near the top of her cohort, and now has her dream career as a midwife, all because someone shared their light. And this is my story so far, but it's far from the end. When I first joined the fellowship, I apologised often for not being more senior because I was the most junior person there, but no one ever made me feel like that, not ever. And this taught me a valuable lesson, and that is that we don't need titles to be leaders. My fellowship and my life and my fellowship has taught me we don't need heroes. We need people who see us, walk beside us as equals, share strength, power, and light when we are unable to find our own. We might not always get it right, and we need to accept that we will make mistakes, but we must use this discomfort as an opportunity to learn, but never as an excuse to stop trying. And I am proud to be a part of our incredible NHS. And it is the only institution that is thread through people's lives from conception to the grave. And there are so many ways we can be the beacon of light in the lives of many. My history and my present make me unique, and I see things from a perspective that many don't see. I see how our policies, guidelines, and practice sometimes promotes exclusion, even when that's not our intention. And as nurses and midwives, we have so much power and light. We need to be brave and stand up for what we know to be right, doing the right thing, not because someone is watching, but because all too often no one is watching. By demonstrating inclusive behaviours and language, we can become role models to all who engage with us from the cradle to the grave, be that our colleagues, our patients, and their families. And as the largest organisation in our country, we have a responsibility to help address inequality, which is the darkness within our society. We must let our light lead the way. We have an almighty power to change lives and even the power to save them. And it is our responsibility to use whatever privilege we have as a beam that illuminates calmer passage in the darkest and stormiest of oceans, remembering that it is our white privilege that caused the waves of racism, but now yielding that power to turn the tide, not by being not a racist, but by becoming anti-racist. We must stand together side by side and work towards safer and better outcomes for our patients, along with equal power and representation within our NHS workforce. It is in the shadows of homophobia and transphobia we must shine our light and brighten up the darkest corners, leaving it no place to hide, and accept that it is our difference that makes our lives so vivid and brighter than any rainbow. And let's not call it a phobia when really it's ignorance and abuse. We have so much to learn from each other and so many ways we can understand and enjoy the complexity and beauty that is our humanity. And we can show our society how to do this by allowing the NHS to lead the way. And the Dame Elizabeth Anionwu Fellowship of Inclusivity for Nurses and Midwives has for me been life-changing. The amazing people in this photo are whom I have shared so much laughter, many tears, journeys of darkness and stories of hope. And they help me to find my power, my light and the skills to become an effective and inclusive leader. And to all of those who walked this journey beside me and shared their light, I am forever thankful. But the reason I joined this fellowship was because I wanted to make a change for women and birthing people who do not speak English. And I want to draw your attention to the most recent Embrace report, which was released in 2023. And in maternal deaths during pregnancy and within 6 weeks of birth, 5% of those women that died were women that didn't speak English. VTE was the leading cause of death, followed by hemorrhage and suicide, and then sepsis. And my argument in all of these cases is if you are waiting for the clinical picture to tell you that something is wrong, actually, in many cases, we are too late. So here are some quotes. Now, for those of you that speak Turkish, you may know which leading causes of death those linked to. But for many of us, we have no idea. And actually, if these were being spoken to, you would still have no idea. So my fellowship project sort of revolved around using professional interpreters and the importance of it. So I'm just going to tell you now that first one should read, my right leg is swollen and I have pain. So, and the second one should read, I feel worthless. So those meaningful relationships with women can only be achieved if we're using professional interpreters and not relying on friends and family, because actually by using friends and family, we're changing their role from supporting the women to actually supporting you as a midwife. And also we should be thinking about vicarious trauma when we're using partners and friends and family to deliver difficult messages. The last one of those messages says, I haven't felt my baby move for 3 days and I'm worried, and I'm going to come back to that. So my fellowship challenge initially started off by just trying to create a credit card sized tool that could be used and worn on a lanyard or carried in a pocket with the relevant contact details for the 10 most used languages within the trust that I worked, and with the telephone numbers and the codes to call them. And actually what I did right at the beginning is I decided to do some very basic research, and I launched a staff survey, and I used some qualitative and quantitative questions on that survey. And to my amazement, it was the qualitative questions that gave me the most detailed information and actually changed what I did for my project. So there were lots of issues that people raised in relation to the barriers of using interpreters, and I've listed the top ones there. So this issue around obtaining consent was quite a common factor, and people saying they hadn't had training or that they didn't have time, and the patients worrying about costs. So what I did from that data is I actually created the card slightly differently. It doesn't look like that either now, it looks much more dynamic. And I created some best practice guidelines that would address those issues that were raised in that qualitative data. And I also then found guidance and policies and merged the two things. So I've put them in a step-by-step order so that you request the same gender interpreter when you ring the telephone number, you introduce yourself in the situation to the interpreter, and then you ask the interpreter to introduce themselves and you to the patient. You then check the dialect is correct for the patient. And I know not all languages have different dialects, but actually it gets really complicated when you start talking about that. And I really wanted to make this simple and usable on the front line. So by just asking that same simple question, is this the right dialect for the patient, to the interpreter, they can check. So that's just simple. Explain the conversation is confidential, that it's a professional interpreter, and that there's no cost, and then ask the interpreter to relay everything you say. And it is this point that you ask consent from the patient, because at this point, I believe it is informed consent. The patient has the right information to make an informed choice as to whether they use the interpreter. And it should never be the partner's consent that you gain, because we would never do that with a white British English speaking woman. We wouldn't speak to her partner and ask him to consent to procedures. We would never do that. So use simple English, speak directly to the patient, using eye contact because you're relationship building with that patient, and then give time to relay that conversation. So those are my guidance, and that's going to be on the back of the card. I just want to go back to some of this data. And after Janet File spoke and came and spoke to us, and she said, you need to go and granulate your data, because I'm very passionate about this subject, and I have been for about 2 or 3 years. I've always been passionate, but the last 2 or 3 years, been really actively looking into it. And she said, granulate your data, contact the Office of National Statistics. To any students out there, do you know that you can contact them directly? I'm sharing that nugget of information from the amazing Janet File. So I did that, and I was absolutely shocked. So of all the women on the Office of National Statistics data, aged between 16 and 49, would you believe that only 0.2% of them are non-English speaking patients? But they represent 5% of the maternal deaths. So that 5% looked quite small at the beginning, but now you know that's big. They are actually overrepresented in maternal deaths by 25 times. So simply not speaking English means you are 25 times more likely to die. And I'm physically shaking as I'm reading that statistic, and I always do. But it's not just them. So let's go back to the births and the movements. So there was a rapid review done looking at data in COVID that HSIB did, where they looked at 37 investigations into interpartum stillbirth that took place between April 2020 and June 2020. And within that report, they reported that 43% of those cases where those babies died in interpartum period were in non-English speaking women, or women who did not have English as their first language. And the availability of interpreters was a major issue. So in a lot of the research that I read, and I've read a lot of research, a lot of the issues are actually things that we as midwives at the front line don't have the power to address. So what I wanted to do with this platform, and I'm really sorry that I'm using it for this, but I really wanted to speak to anybody who works in NHS England to really think about what they're doing and making sure that what we do is meaningful. There is clear guidance, but actually who's accountable for the implementation of that? And is it clear enough? And if it's there, actually the frontline staff need to know that. We need to be considering language and communication needs as a protected characteristic, because I believe if we do that, that would be an umbrella that would capture an awful lot of people, not just non-English speaking people, and actually it means that they would be protected by law. And the provision of the fit for purpose interpretation services, because we don't really have that at the moment. It's very difficult to get interpreters outside of office hours. It's very difficult to get the right interpreter, like a female interpreter, and then to create a library of shared resources that all staff can access on certain things like risk of VTE, fetal movements and how important that is, just some very generic things that actually all NHS trusts can access, rather than each NHS trust doing its own thing, because that's such a poor waste of resources. And then also to consider investment in external resources and making sure that these women are included in data, and when they're doing serious case reviews, really considering what impact that language barrier might have on these women. And then again, I've created a list of considerations for trust levels. So things like making sure prescriptions are in their language, but the prescription stickers are for the patient, but yet they're written in English. Well, if you know that patient doesn't speak English, it's pointless. And they don't know what medications they're taking or when they should be taking them. And using simple English. And this is something we're really bad at. There's so much evidence about the importance of using simple English to include all patients. And yet we still hold on to words like obstetrics and put them on letters. And that's a word that doesn't translate if you're using Google Lens. And really to think about how we can use how patients can feed back. So for instance, the PAL service, I looked at about 15 different PAL services on their landing page, and out of that only 3 of them had considered the fact there was a language barrier for some of their patients. Only 1 of them had put the information on how to contact PALs through in different languages. So yeah, it's looking at all of that information. So this is what we need to consider when we're doing this. We need to make sure it benefits the patient and that it works on the front line, and to engage your staff and give them time and the infrastructure to do this properly. But I want to finish with just some stories that have been shared with me, which I've put together in a poem. And this is the very reason that I attended the fellowship and the reason why I want to create this change. Because actually, to me, women-centred care means that every single woman should be treated with equity in order to give them the same quality of care. So these are stories, and I want you to listen and just bear in mind that every single verse is a different story from a different person. And the poem is called Hear Me. You don't know if I'm safe in my home. You don't know if I have the freedom to roam. How can I explain I've experienced harm? How will I know when to raise the alarm if you talk to my abuser to hear me? You haven't involved me in choices of care. I've not attended appointments, didn't know when or where. Just seen the doctor and don't understand the plans. I'm not sure what these pills are in my hand. You've explained to my child and not me. I've questions and don't have the language to ask. I've fears, but you can't see beyond my mask. Intimate issues I need to discuss, but I've come with a person I don't really trust when you speak to my neighbour to hear me. I am nervous and don't know what lies ahead. My experience of birth just fills me with dread. I don't understand what you tried to explain. My informed consent hasn't been obtained when you ask my husband and not me. For when I am hungry, thirsty or low, without an interpreter, how will you know? If I am in pain or petrified by fear, how will I know your concern is sincere if you talk through my family to hear me? Thank you very much.
Wow. Thank you, Maria, and thank you, Calvin. My goodness. I feel, oh, my heart's racing a little bit, Maria. And that
When I
poem
read
was,
that, that's real stories, and that's just
yeah,
whatever I do, I need to remember the reason why I'm doing it, and it's for the patients. They deserve to be respected. They deserve to have equity of care. They deserve to be listened to, and they absolutely deserve to be safe, and so do their babies.
absolutely. It was beautiful, beautiful. Thank you so much for sharing that. Now there's some comments coming through. Now remember, if you've got some questions for Calvin or for Maria, please address them through to Paul. And they come through to me, which is why I look over there, because I'm looking at my other screen. And we've got some nice comments Becky Hertogs from UWE says it's very powerful and touching. Thank you. Jill Phillips says so powerful when what we see and the assumptions we can make, see the person, which is just as you were saying. It's lovely. And Pretty Patel, this has been a very powerful and enlightening account, and thank you for sharing your story. You're right. Anyone can be a leader. It's not guided by your title. Fantastic. Thank you, Pretty. It was lovely. And Patience Pounds, hi Patience, says absolutely fantastic presentation, Maria. Thank you.
Thank you, everyone.
And Lorna Hollywood is saying, hi Lorna, is saying this should be national policy across all NHS services. Bravo, Maria. So that's maybe will be. I think.
All I want is for one person to listen and do something.
Yeah. And then Philandra, hi Philandra Costello, says, wonderful work. Just a question, how trained are the interpreters in translating the medical information to the patient?
So that's an issue that they should be trained and they should be accredited. And when I was talking about future planning, I believe that the NHS are oversighting. So we're not supposed to be losing our colleagues to interpret because they haven't had the right training. And I think future planning should involve using these wonderful bilingual staff that we have and actually creating a specialist course to give them the accreditation to be able to use that medical language and bridge that gap, but also to make sure they're paid properly as well and that they're respected for that role that they hold. We've got all these wonderful international midwives and nurses that have come into the NHS to help us, and actually we should be really using their skills, and it's almost like they come and we expect them to work our way. Well, let's sort of join together and figure out what skills have you got, what can we use, how can we promote those, how can we give you that accreditation for having this language and making sure that it's measured. So, and appropriate is what I'm saying. It's not measured, but that they've got that language, because I can't really see how we're going to go forward and have more and more people that don't speak English, and actually we're not really doing anything for future planning. And I think that is one way. And another thing is as well that I'd like the NHS to consider is to create a centralised call centre that's available 24 hours that could be linked to the 111 service, where people are then given accurate, good hours to work, that they're seen and respected as the professionals they are, because interpreters are professionals, and that they have like a regular income, because sometimes I feel that it might be like an ad hoc service, and I don't know if that is the case, but that's what it feels like in the NHS when you're trying to use it at 3 o'clock in the morning. So
yeah, it's difficult. And I guess if you as the midwife are asking the questions anyway, and I think your point about trying to go to straightforward, simple English rather than getting technical might be relevant here. If you're actually asking an interpreter, maybe they don't need as many medically things. If you're explaining it in simple terms to the interpreter, they can transfer it to the person, can't they?
Yeah, absolutely. Yeah.
So I think one of the things, Maria, you're hedging towards is this thing Macpherson told us in the Climbier report many years ago. Macpherson talked about joined up thinking and working. So to those of our viewers who are joining us online, the Climbier report was a report on a young child, Victoria Climbier, who died because of abuse and neglect. But when she was missed at school, nobody reported. When she was missed a healthcare appointment, nobody reported. When something went to the police, so you had all these agencies who look after our welfare, they weren't joined up working and thinking. And I think when you talk about, when you call 111 and you get directed, what we need to see, those words of Macpherson still stand. We need to have joined up thinking and working. And I think, as we've grown, as services grow, we've become sort of isolated in some respects, and we need to come back to that joined up thinking and working.
I think that's a good point, Calvin. Yeah.
And I've been trying to raise my head above the pulpit for this for quite a while. And it was a fellowship that gave me the courage to actually start reaching out and saying, I want to come and speak about this. And I want to really talk. And it was outside of, I took my own chair to various meetings, but actually to talk about it outside of the trust and to use this platform is phenomenal. And some of the things that quite often come back to me, and I could have done a huge presentation because it's such a big issue, but quite often people give me stories about when the interpreting hasn't worked properly, or, I've heard this story about, this interpreter saying this when actually this was what was said. my argument, if there's anything that's happening like that, is that if you had a faulty Doppler or blood pressure cuff and it didn't work on one occasion, it wouldn't stop you using it. What you would do is you would get another one or you'd report it. So actually, if we're asking the NHS Trust and the NHS England to be accountable, we on the front line need to make sure we're reporting those incidences. So because actually this is just so much more than a communication issue. For me, I strongly believe this is a patient safety issue. That is it, black and white. It is patient safety. If we are not communicating and we're not sharing this information, then it is a patient safety. If we're not getting consent, then what are we doing? It's obstetric violence. So actually it's patient safety. And I think we need to be really clear and use the language that really makes that black and white, that it's not ambiguous, it's straightforward. This is what's happening. And actually, if it's not working properly, if something happens, you can't go to an interpreter, report that, and it should be reported back to your trust, and you should do that through your incident reporting. And I think if your trust starts getting lots of incidences reported, then actually it's going to really highlight the issue to them, because the chances are that people in management that are not working on the front line might not quite know how problematic this is for us, and I'm pretty sure they want to get it right as well. So it's our responsibility to report it.
Because I suppose, because the only thing I was thinking is, as you're talking to a patient through a relative, for example, you can fool yourself into thinking it's okay, I've asked the questions that need to be asked. But what you've pointed out is we're only getting a nibble on the edge, and maybe not even that. Kelvin.
Yeah, I thank you, Sue. Just to follow up on what you're saying, and we know sometimes relatives, patients wouldn't want to say exactly what they're affecting them to a relative or a child, and we know we're moving away from those practices. But Maria, looking at the data Maria presented tonight and listening to her speak now about critical safety and critical patient safety, I think it's really important. What Maria is uncovering for us tonight is that interpreters, people we use, particularly in maternity care, because this is what we're focusing on, women who died, and you saw, give us the statistics in Embrace report, etc., and those who don't speak, the language. What you are saying is that interpreters are a human factor in providing safe and effective midwifery and maternal care. That's what they are. So I think we now need to move our thinking and stretch it to the point, because you made the point really nicely, Maria. If a blood pressure cuff or a Doppler is broken, we report it. That's a human factor, right? Equipment. So another human factor, which we've never considered, is interpreters as a human factor in actually providing safe and effective maternal stroke midwifery. I'm not a midwife, okay? So I want to make sure I use the right terminology, but, providing that care. And I think that's what it is. They are a human factor, and we've ignored that.
Yeah, absolutely, Calvin. And I think, we're talking about midwifery tonight because I'm a midwife, but actually the issue is so broad. It is across the entire NHS. Outcomes for non-English speaking people are really, really poor. And also, it's not just about not using partners and family and friends, because actually if professional interpreters need to have training to be able to relay these conversations, what makes us think that somebody with their second language have the skills and the ability to interpret what we're trying to tell them? And you don't know what you don't know. So I've know of cases and I've heard of stories where the partners think they've interpreted okay, and actually it turns out that the patient's been diagnosed with gestational diabetes and raised blood pressure, and the partner didn't know what those things meant, but he didn't know what those things meant. So it's all about making sure that if you've got to be a accredited interpreter, what makes us think that a 15-year-old child, which we shouldn't be using children anyway, or a partner that's got English as a second language, I think we're just absolutely so naive to think that is the case. I could barely go into France and order a sandwich, let alone tell somebody about an induction of labour. So
that's true.
And I think that's what we need to think about. Is this is such an issue, and you, like I said earlier, you're changing the role of the birth supporter or the partner that's coming to that appointment, and that's not fair on them either.
No, that's grand. I'm going to move now. We've got a few more questions coming through. I've got Sam, hi Sam, who says, is there anywhere we could get that poem? It was very true to current frontline staff, both nursing and as a paramedic. I don't know.
I've contacted the Royal College of Midwives and asked them if I can write an article, because I just want to get this issue out there, and I've asked them if they would publish the poem, because I can't talk about the issue without bringing those stories with me, because that's why I'm here talking about all of this today.
So I'll be publishing it. You didn't add it to the article you've just done for the forum?
No, I don't think so, because I don't think I've done an article. I've shared some links about
Oh,
existing
sorry.
policy, and I've shared some really interesting research that was done through a Freedom of Information Act, where actually they looked at maternity journeys and looked at the average of 13 to 16 appointments for these women, and actually established only on average on 3 occasions are interpreters accessed, which means that actually on 10 to 13 appointments we're not accessing interpreters. So how have we had consent for anything, you know? So so I've shared that as well, and also the guidelines. But the NHS Scotland guidance I really like, because it really does give the reasons why you shouldn't use partners. But all the guidance that exists is there. So any NHS trust that want to implement it, it's there. I've shared it.
Yeah, they're on all the resources. All those ones have been added onto the resources. So Sam, hang on. The poem will be out at some point. So
on my
just
Twitter
hang
account
on a
as
bit.
well, I think.
Follow Maria on Twitter. That's it. That'll be it. And Parveen Amin says, thank you very much, so much. This is good. I'm currently doing my dissertation on language barriers and informed consent. How can I get in touch with you, Maria? Ha 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 ha. I should think Parveen is very excited now.
Through Twitter. Through Twitter. Maria Rowntree will find me quite easy.
Yeah, fantastic. Okay, and then patience again. Question for Calvin now. I'm working on inspiring inclusion in research, and I'm presenting to a group of researchers next week. Any message for them?
So if you're presenting to a group of researchers, I think one of the things you need to say to them is inclusion matters from the beginning of the project. So if you're talking, Professor Ruth Northway in Wales and Ruth Oshikanlu here in London and myself, we wrote a chapter in a textbook called Navigating the Maze of Research, edited by Professor Deborah Jackson and 2 other people. And in that chapter, we discuss the whole ideas of inclusivity. So it starts at the beginning of the project. People should be, so you should think, have I got the right team of people? Do I have the right makeup? How, even if it's age matching, gender matching, race matching, all those issues you would look at. You should also look at, how is the report going to be written about? Who is the research being done by? So you ask these questions, and this was one of the things. The NIHR has funded me to do a project which starts next week, researchers in nursing and midwifery, because we went to the NIHR and we said, look, when we go to scientific conferences, etc., there isn't much Black and brown nurse researchers. So, and we know bias exists in publication even of their papers, and how do they get grants? So the NIHR has funded a pilot project. I'm pleased to say we've got like about 18 applications for the program. And we're going to look at how we develop them. And we're going to take them through these things. So I think one of the things I'm saying to you is, have you got inclusive members in your team? So for an example, I was approached by 2 white cis, gendered male who said to me, oh, we're going to do some work on transgender people. We'd like you to be part of this research team. And I just said to them, and who is the transgender representation? When you get somebody from the transgender background, let me know. And it's those things. So I think your tips are for them to start thinking of their research team, who represents whom, and how are they going to do it. That's the start of inclusion, really and truly, to get equity across the project.
Fantastic. And keep in touch with Calvin, I'd say. There we are. Thank you very much for that. Now I've got Pretty Patel saying, how can we encourage staff to use resources such as Language Line, as we often hear from our students that staff do not use the resources despite being available? Whoa, how can these use of resources be improved?
So that was why my project changed, because when I applied to the fellowship, I thought, oh gosh, why aren't people using it? And I would get really cross because I would have stories about people that had seen such and such a hospital, and it was various hospitals. And it was actually doing the research that actually taught me that there's various reasons why staff don't use it. And actually the guidance from the government is that we should be having training, that we should have time, and that we need accessibility. So it's okay having the service. And I've raised this in various meetings with various people in various hospitals, but it's actually oh, well, it's really simple to use. But actually, it turns out, and those guidance that I've created shows that it isn't that straightforward to use. If you don't use it all the time, I mean, I used it quite a lot, but actually, if you only use it once a year, then it's something that you become quite anxious about using. And you wouldn't expect someone to go off and use a Doppler without training. So why are we expecting them to use what quite a complex communication issue and just expecting them to go off and do it on their own? So I think actually we need to make sure as trusts that we're providing that training, even if it's just an accessible video. That's what I did. In my trust is I actually did it as part of our mandatory training. So every single maternity member of the workforce will be watching it, and I'm just demonstrating how to use it. And then, like I say, this card will have the best practice guidance on it. So it's got that step by step. So if you are, if you haven't been to the training for whatever reason, you've got that guidance, that step by step. And it's actually what we need to do is make sure we're facilitating and we're enabling midwives look at the barrier and deal with it. And so that's why that research that I did was really important, and it's really given me the passion for understanding research. And in fact, I'm hoping to do some research myself later on. I'm putting an application together at the moment because it's so valid, and actually you can't really have change if you don't understand who that change needs to address and how to address it. So yeah, so just encourage training and facilities.
Training.
And
Okay. I've still got a little list of questions coming through. So thank you for that. We've got Chris Warren, Calvin. How did you get the funding to set this up and keep it running? What's stopping it spreading out to the more nations? Thank you, Chris. Good question.
I take it Chris is asking for a question around the Dame Elizabeth Anionwu
Yes, I think so.
Fellowship. We know we're living in times of austerity, if that's the right word to use. And we are hopeful, we're waiting because the financial year is about to change. So our bid is in with our NHSE and is being reviewed for the next round of funding for the Dame Elizabeth Anionwu. So we've written our first report, we've disseminated it now, and we're hoping that we will be able to spread it. We need to meet with the CNOs and the CMIDOs of the other nations and actually look at how we can, work things together. So hopefully we could roll it out. And we don't want it to be it just happens that I'm based in London. We don't necessarily need it to be London centric. We know there are lots of people outside of London who need to have programs like these. So we are aware of that as well.
Fabulous. Thank you for that. Okay. And then we have a question from Kathy, and I know we're running short of time now. This is the quickest hour of the week. Kathy says, how do I know when an interpreter is of a group who's acceptable to my client? Is any interpreter better than none?
I don't know. What do you mean by that? So are we talking about a different cultural background?
It could be a different cultural background. I would imagine
if they're a professional interpreter, they should be non-biased because that is part of their registration, I believe. So actually what you need to do is just check, for instance, the dialect is correct. And actually they shouldn't really be sharing information about their own cultural beliefs. It should be interpreting the conversation, and it needs to be repeating what you say. So it's about using a professional interpreter, not just using any person that they've come with. I hope that answers the question. If they don't, please can you let me know, and I'll see if I've not understood the question, I'll answer it again.
Okay. And we've got Jenny Hall. Hi, Jenny, who says, so powerful, Calvin and Maria. How can we make sure translation support becomes more of a priority? Gosh, that's the $1,000 million question, Jenny, as always.
And that is I think just actually, again, with the language we use, and this is about language in general, but I think sometimes we use language that actually means that we don't then hold accountability. For instance, when we talk about unconscious bias, when really it might be structural racism. So when we talk about unconscious bias, actually that doesn't give anyone any ownership of that. But when we start saying structural racism, well, then we're actually saying this is the problem. So I think by talking about this issue, we need to be saying actually this is a patient safety issue. It's not a fluffy part of care that we consider as an addition, it's something that is incredibly important. And actually what we're doing is we're really excluding women from making informed decisions, informed choice, and even giving informed consent, which is it's a legal requirement of care, and it should be informed and it should come directly from the patient unless there is a legal mental capacity issue around that. So, and I'm pretty certain that not speaking English has nothing to do with mental capacity. So why are we thinking it's okay to get consent from someone else? So it's kind of, I think, talking about it as a patient safety issue, raising these figures, saying actually they are 25 times overrepresented in maternal deaths. We are accountable for that. Every single one of us that has been involved in any of that, even if you're looking after a patient and you haven't got an interpreter because you didn't have time, you didn't know how to do it, we are all accountable for our patient safety, no matter who that patient is. And the most important thing is that we listen to every single patient. We listen to every single one, and we can't do that for these women without an interpreter.
Well, I think your statistics were stunning, Maria. I think that, and I think it's hearing your words saying it's not fluffy, it's a patient safety. That's almost a beautiful way to end. But I just want to maybe, oh crikey, there's still some questions, but we are running now out of time. But we've got some comments from Kate Frith. Says this is a fantastic evening. Both presentations were so helpful. Also, thank you for the poem. I think it's so important to keep using real voices in addition to the statistics and data. And Diane Garland also says, thank you. This subject's so important. Sarah Smith, this is very valuable information relevant for all areas, departments and fields. Thank you to you both. And Cheryl Bonnie says, thank you, Maria. That was incredible. You're a huge inspiration. I was very lucky to work with you last year as a student. That's lovely.
I remember Cheryl. She was working with me the day I found out I got a place with a fellowship,
Oh,
and I literally jumped up and down and gave her a huge hug, and she'll remember that. Thanks, Cheryl.
I think she might do. And I learned so
does.
much from you. You impacted the care I provide. That's lovely. And finally, no, I think we have to come to an end there. We'll send the questions that you have to Maria and Calvin, and if they are able to answer, they will do, I know. But as I think we have to come to an end. This hour is the quickest in the week. And I want to say a huge thank you to Calvin and Maria for joining us. Now, this conversation, I think, is going to go on and on. And as a little homework, can you imagine yourself being in a foreign country and being unwell and not being able to speak the language and not be able to have people that can understand? I mean, most of us are very lucky because many countries will have English speaking people, practitioners. It's quite humbling, actually. It's more than humbling. It's very humbling. But think about that, because it's scary. And for those women and families that come through our care, it's big scary. So we need to really address this. And I love, Maria, not fluffy, patient safety issue. That's wonderful. And thank you, Calvin, for all the work you're doing, pushing this forward. Fantastic, absolutely fantastic. So I'm going to say also thank you to Angelo, who's behind the scenes, making sure everything's going to be recorded. And remember that you can share this with colleagues, and do share it. This is really important. And you can share this on your little mobile phone or whatever when you get the link, and have a discussion. Look at what you're doing in your unit. Look at what you could do, and think about how you could use some way of training people and using the resources you have well. Thank you also to Paul, who's been putting the questions through to me very quickly and beautifully. Now, resources will be available for those of you who want the podcast at 6 o'clock in the morning on Friday. It'll be there. My goodness. And it'll be coming through in the newsletter as well. Don't forget the booking for All Ireland Festival in Dublin on the 9th of April and Midlands Festival on the 14th of May. And also next week, we've got Elaine Moore, who'll be talking about the work of safeguarding midwives, providing continuity to pregnant substance users. So it'll be really interesting also. But in the meantime, I'll say another big thank you to our lovely speakers. Thank you to all of you for joining us this evening. Take care of yourselves, and we'll see you next week. Same place, same time.